We're here at the 21st CROI here in Boston, and we're visiting with Ken Sherman, who has done a lot of great programs with us over the years, updating us on the hepatitis area of the diseases that we are facing at these conferences and challenges we're making and the advances we're making every year. And this year has been particularly important for hepatitis, which is your specialty. And we brought you here because it's such an opportunity to kind of give a background on the disease, and well, you'll go through the whole program. So I'm hopeful that we can, get everything we need to that'll give people a background on hepatitis and the use, and maybe the sense of when to use it maybe as well. Mm-hmm. So thank you very much for being here.
Thank you. So this is a really exciting year. Because in this year, we begin to see the emergence of new treatments for Hep C that are highly effective as treatments in those with patients who don't have HIV infection, and globally, treatments that will cure 90% plus of most patients who have hepatitis C. Mm-hmm. Now remember that about 4 million people in the United States are infected with hepatitis C. And among the 1.1 million people living with HIV infection, approximately 20 to 25% are co-infected with hepatitis C, which causes accelerated liver disease, leading ultimately to end-stage liver disease and increasing the risk of developing liver cancer. So being able to cure hepatitis C represents a tremendous advance forward. In December of 2013, we saw the approval of a new agent, sofosbuvir, which can be used combined with Peginterferon ribavirin, or used with just ribavirin in certain patients to highly effectively clear hepatitis C infection. And during this year, we'll begin to see other drugs in other classes emerge. Some of these will be combinable with each other. And before this year is out, the standard of care will again change to interferon-free therapy for most patients. Mm-hmm. So we eliminate Peginterferon, which has been the mainstay of therapy, which has not been as effective always as we liked, but also is accompanied by a host of side effects in those that take it.
Very challenging to take that. And it's also a longer course.
And longer treatment periods. So we are seeing better efficacy, shorter duration of therapy, all oral therapies, and the opportunity to cure most patients.
So it's almost at the point where you could say today's the day to make the move, but you might want to wait a little bit longer because, like you said, there are other drugs that are coming out, and they're going to know pretty well whether you're a candidate for a drug based upon your tests that they do.
So there's characteristics that you need to look at in each individual, and those include what is the genotype of the virus. The genotype is the family that the virus is in. Mm-hmm. In the United States, most are genotype 1. And now we talk a lot about subtypes, sort of the children in the family. Mm-hmm. And subtypes have also emerged as important predictors of which drug choices you might make. Mm-hmm. The second is the stage of liver disease. If a person has been infected for many years, their liver disease has progressed, and over time they've built up scar in their liver. Some people progress quickly, some people progress a little more slowly, but the amount of scar in the liver has a significant effect on, again, the treatment decisions you make with regard to drugs, and also key management issues for that individual patient. You need to know whether the patient's been treated before. So a patient that has never been treated is now referred to as a treatment-naive patient, not because they don't know anything, but because they simply have never been treated.
Their body doesn't know anything.
And a treatment-experienced patient, one who has seen a prior therapy, which could be interferon, pegylated interferon, with or without ribavirin, and in the last few years with the first generation of protease inhibitors, either telaprevir or boceprevir. The response to whatever the prior treatment is will have some impact on the choices and decisions that your doctor will make when making a decision about how to treat you.
How do you a doctor that's going to treat you for this with these combinations, should they should be experienced. They really want to know all the nuances to these new drugs that are coming down the pike. They should be really experienced in this field. It shouldn't be just a regular medical practitioner. It should be somebody that's a specialty.
Well, of course, experience matters in all things in life. And
so it's important decisions to make. This may be a second good chance or a first good chance to.
And there are big decisions, and there is some concern that the ease of use of the new regimens will expand rapidly the number of care providers that try to use these medicines, and they may not fully understand all of the nuances. That said, it is important to expand the pool of those that are treating, because we have lots of patients with Hep C and a relatively small group of what we would call experienced care providers. And so meetings like this at CROI are a key place where some of the knowledge of how to do this is disseminated, and hopefully for many will just be a starting place and will lead to continued interactions, especially on the more complex cases, with those who have more experience.
And also continuing medical educational programs and so forth. I'm sure there'll be more of that. I mean, I don't know whether it's pharma's going to be doing all of it, but, and then of course the other thing is our community needs to be educated, which is hopefully what we're doing here.
Yes.
We'll have another program that'll talk more specifically about the drugs and the goings on, the research that happens here, and maybe more of the hall talk. But I think it's the reason that I asked you to do this is because it's so important for people to understand some of the background and the whys and the wherefores, and then we can move on to the research, and if you can dig into it further, there's plenty of place to get information. But I think that this is a good starting point from right here, where we can understand how this disease works. What do you find is going to be the point where we really have most of the armamentarium in place? Would you say within the next year we'll have many of the choices ready to go?
I think before the end of 2014, we're going to have most of the tools that we need for most patients. Now, the ultimate is a single pill taken for a short period of time with few drug interactions or side effects that will cure all of the different types of Hep C, such that one wouldn't have to do the testing. We have a fancy word for that, a perfect pan-genotypic drug. But the perfect drug will not require you to know what type and subtype you're dealing with. We're a few more years away from that. So if one looked in a crystal ball, I would say we're probably within 2 to 4 years of having that perfect treatment. That should not be a barrier to treating many, many patients right now. And in fact, a continuing issue in the United States and elsewhere is actually the identification of patients. Still, many patients that have hepatitis C and other forms of hepatitis don't know that they have that hepatitis.
Is there anything you can say as far as how a person might get a sense that they might be needing a test to find out if they're hepatitis C?
Well, if you're HIV infected, you should be tested for hepatitis B and hepatitis C. And
how often? Should it be twice a year or something? Or?
Well, that's an excellent question. If someone is continuing to engage in risk behaviors that would lead to acquisition, then monitoring at least yearly is probably appropriate. Some have recommended that twice a year following liver tests would indicate a change. A bump in liver tests would indicate an injury, and an injury would suggest that you should be looking for the acquisition of an infection. In those that are not being exposed to risks that could lead to infection, then it is probably less important to check frequently. And
But standard blood tests would give you some indication.
If you interpret them correctly,
yeah.
and that's often a problem. Many clinicians see a moderate bump in a serum ALT level, which is a standard chemistry obtained when most people see a physician for a checkup or follow-up, and they may not follow up on it if it's not 5 times or 10 times what it was previously, but one could have acquired an infection and already being in that cooling off phase of that with relatively modest increases as the only sign.
So there's a pretty big bump that you may not catch, and you're on the downslide from that.
That's
more normal, isn't it? Yeah.
Exactly. And so the astute clinician will see a change probably of twice what that person's baseline is, and should be asking questions about do we need to rescreen for those infections. For Hep B, which is a vaccine preventable disease, it makes sense to make sure that someone has adequate titers of antibody following vaccination and boost as needed with vaccine boosters to try and maintain the level of antibody that would prevent a new hepatitis B infection.
Yeah, and there's always this issue then of reinfection. So
Right.
people that get cured, then they can be it's nothing to stop you from being reinfected.
No, that's exactly right. So for hepatitis C particularly, there are many, many cases now of reinfection that are well described. And the fact that we have a highly treatable disease does not mitigate the responsibility of trying to prevent the next infection, especially when these treatments are incredibly expensive. And there may be a frustration by society as a whole to continue to pay for treatment after treatment, even though it's a curable disease.
Will there be any built-in resistance to the new infection, or would this be an all-over?
So that's an excellent question as well. We don't know that for sure as we move into some of these new drug combinations. There is a suspicion that certain regimens will lead to resistance profiles that will make other regimens less likely to respond. But if you got a new infection, in other words, you were cured, that virus is gone. And the new infection will carry the resistance profile of whatever that person had been exposed to in the past. So if that patient had never been treated, then there probably won't be an issue. If that patient had been treated and failed treatment,
then that resistance is
then
built
that
in.
resistance may be built in for certain agents.
Well, is there anything else you want to bring forward? Because I really think this has been very helpful. You know, I understand that it's been helpful. I hope that the audience is really tuned into this and understanding the nuances that we're talking about here.
Thanks, Fred. There is one thing that I do want to say. Cure is very important and will stop the progression of liver disease due to hepatitis C. But the liver disease that's there doesn't instantly disappear. And for that reason, as part of the workup process, the staging of the liver disease is very important. For those with more advanced stages of disease, what we call cirrhosis or near cirrhosis, there's a number of long-term implications even after the virus is cured. Among those is the continued risk for development of primary liver cancer, also called hepatocellular carcinoma. In someone with cirrhosis, the risk of that for several years after a cure is still 1 to 2% per year. The window of being able to appropriately manage a liver cancer is very short. So we have already seen patients who were cured 5 years ago, thought that they were done, and then, because no one was screening and no one was following up, came back with a liver cancer that was not resectable nor transplantable 5 years later. So we won the battle, but we lost the war. The other is to be aware that later stages of liver disease can cause other problems, including neurocognitive problems that affect behavior, may increase irritability, disturb sleep profiles, and lead to decreased concentration and ability to do complex tasks. And at the earlier stages, many of these are quite subtle. We do have treatments that will help this. But again, simply curing the virus does not make the risk of those things go away in those with more advanced liver disease.
Okay. Well, some of this has been a bit morose, but some of it's been very hopeful.
Well,
So I think we have an opportunity here that we should take advantage of to avoid some of those deep challenges down the road. And
but the earlier we treat someone, the less likely any of those bad outcomes will occur, and we can change the game. And now we're prepared to do that.
so be tested
Be tested.
and likely be treated earlier, better.
Yes.
Thank you so much. I really appreciate your time here with us.
Thank you.
And I hope you learned something that we can take to the doctor.
Thank you.